Well, I'm really excited to have our speaker here today. Thank you so much for joining us. We're hosting our next installment of our speaker series, and it's going to be about everything related to IVF. Before we dive into the topic at hand, I wanted to quickly introduce myself. My name is Amy Devine, and I'm the CEO and founder of Oova. We are an at-home fertility diagnostic that monitors two hormones, luteinizing hormone and progesterone through urine. We quantitatively measure these hormones to determine your most fertile days and confirm if you ovulated. Our test is completely personalized, so we don't wait for your hormones to hit some arbitrary threshold. In addition, you don't have to mail samples to a lab or visit a clinic to interpret your results. We provide you with that lab quality accuracy in the privacy of your own home within minutes. So if you're interested in learning more or for more information about Oova, you can check out our website at oova.life. Just some housekeeping points. We're going to have a short presentation by our guest speaker, followed by a Q&A. And I believe, Suzie, you're fine with the Q&A during the talk. So if you're comfortable, jump in or drop them in the chat box. Today, we're going to be doing a really deep dive into everything IVF. And I'm thrilled to have Suzie Devine from Binto join us tonight. Working in healthcare for several years, Suzie has seen the healthcare journey for what it can be. Long, frustrating, overwhelming, and expensive. Suzie's also seen patients bloom with renewed purpose. When anyone is on that journey, it's hard to know where to turn or whom you can trust. To further help provide for patients with network access to individualized care focused on reproductive health, Suzie launched Binto in 2016, a first-to-market direct-to-consumer supplement company that offers personalized daily supplement packets tailored to a woman's specific needs and reproductive stage, based on an in-depth survey created by Suzie and her medical advisory board. In the first year, Suzie worked endlessly to develop Binto, all while working as a nurse and teaching women's health clinicals to nursing students at Villanova University. During this time, she developed powerful relationships with patients, sharing in the bad news, celebrating the good. It was these relationships that enabled Suzie to truly experience the power of human connection, and she took these viewpoints to shape her latest endeavor. Soon after launch, Suzie and her team found that the community of women were interested in speaking to professionals like herself to address in-depth medical and wellness questions that went beyond supplements. And so Binto evolved from an over-the-counter product company to a women's health and wellness service. Now hosting a new telehealth platform, Binto offers all women access to health and wellness providers via their team of physician assistants, registered nurses, registered nutritionists, lactation specialists, and more to meet the needs of each reproductive stage. So Suzie holds a bachelor's from the University of Virginia and a master's degree in nursing for health leadership from the University of Pennsylvania. She's also an adjunct professor at Villanova University School of Nursing and a 200-hour certified yoga instructor. My God, Suzie, thank you for making time to speak with us. Thanks so much for joining us.
That intro was a mouthful. That's so I didn't know you were going to read that whole thing. That's so sweet. Well, thank you for having me, and I'm excited to be here and work with all of you. And I think we'll dive in. But before I get started, I do just want to reiterate, being a nurse and teacher, I love questions. So like, don't be shy. This is like a, your personal time. And I want you guys to get the most out of your time and out of the webinar. So if you have questions, please unmute yourself, interrupt, ask, I don't mind. Or if you're nervous to do that, you can throw it in the chat and I will try to keep an eye on that. But I'm going to go ahead and open this up. Okay. So tonight we are going to learn how to put our best egg forward and sperm in our discussion for IVF 101. Again, I'm Suzie. You already heard enough about me, but I am a certified fertility and IVF nurse, worked in at the bedside for many years prior to starting this. And I still am a nurse today. Our objectives for today. I want all of you to gain a full understanding of IVF, the processes, procedures, so you can begin to develop your own fertility and IVF care plan. I don't know where each of you are in your journey, but I assume if we're in an IVF 101, we're probably teetering on like thinking about starting this, or you're probably already with a fertility clinic and know that you're going to have to do IVF as your next step. 1 in 8 couples, I am one of them, have infertility. So I'm literally right there with you. I've done several rounds of IVF myself. So I not only understand this as a provider, but now as a patient. Okay, so I want to do a quick review of the reproductive health system, just, because we don't learn a lot in science class. We're going to do some stats, outcomes, and then we're really going to get into depth with IVF and discuss how that works. All right. So the female reproductive health system is pretty complex. We have our uterus, which is right here. We have our ovaries, which are right here, and they hang off the fallopian tubes, which are these orange parts here. This is just one part of the overall reproductive and endocrine system that makes women have an ovulatory cycle and then get a period. When we're trying to conceive, we need everything to be in perfect balance. Hold on, I have a question. Oh, no, Oova. We need everything to be working and in balance. So this means our whole endocrine system has to work appropriately, and we have to have a healthy functioning uterus and a healthy functioning ovaries and fallopian tubes. Our ovaries are the organs that contain our follicles, which are little tiny sacs that hold all of the premature eggs that we will ever have in our lifetime. So all of these components are really, really critical to our overall female fertility. And I think it just helps to touch base on this again, because we can have different types of infertility diagnoses. It's not just unexplained. It's not just someone's not ovulating. You could actually have like a physical issue with fallopian tubes or your uterus. Okay, so I am not going to review all of this, but we have 4 phases of the menstrual cycle, and this is what makes us ovulate. And so Oova obviously pinpoints where we are in this phase, which is really cool. So this is where your hormones are very involved, and we're going to talk about those next. But period phase is when you're bleeding. Follicular phase is when your hormones start to surge, like your estradiol level, and your follicle stimulating hormone. And that's when we're going to start to grow some eggs on our ovaries. Then one of them becomes mature, and we have a surge in luteinizing hormone, and we ovulate. And then we go to the luteal phase, where hopefully that egg has fertilized to create embryo, implanted, and we become pregnant. But that does not always happen. All right. In IVF and fertility in general, we talk a lot about hormones. Hormones are little receptors that sort of are carried through our blood, and they turn specific cells into action. So these are the hormones that make the menstrual cycle happen and make ovulation happen and help us get pregnant. If any of these are off significantly with a hormone imbalance, it could lead to infertility. So this is why we want to monitor and why you're going to have a lot of blood work done, and we'll talk about that later. So AMH, or anti-Müllerian hormone, is a part of what we call your ovarian reserve workup when you're with a fertility clinic. This is often touted as a way to predict our fertility, but actually the only predictor of fertility is age. Hormones give us a great little window or snapshot into where we are at a specific time, but it doesn't mean that you can't go out and try to get pregnant that month, that you will or will not get pregnant. So AMH is something that we use in IVF to help come up with your medication protocol. Estrogen is your primary sex hormone. It's secreted by the ovaries. Testosterone is a male hormone, but we as females have it. This plays a really big role in women, specifically with PCOS, because you're going to have more testosterone. And many women with PCOS end up having ovulation dysfunction and may need to have IUIs or IVF. Follicle stimulating hormone is the hormone that grows a mature egg. And as we age, this one actually steadily we have to start producing more and more of it to produce an egg, because so our body's working that much harder. This is the one that we often look into when we're looking at someone who might be perimenopausal. Luteinizing hormone is what makes us ovulate. Prolactin out of the pituitary plays a big role. If it's off, it can cause ovulation dysfunction. Or thyroid, with the little gland in the base of your neck, is critical to fertility and our ability to stay pregnant. Progesterone, and then cortisol, the stress hormone. So I don't want to spend too much time on this, but I think it's good to have a little bit of a background on our bodies before we dive in. And of course, we can't have IVF without sperm. It's half the equation. If the goal of IVF is to make embryos and not to freeze our eggs. So the male reproductive system is pretty complicated, but I'm just going to give you a little bit of a rundown. We need healthy sperm to create an embryo. So that sperm has to get through and fertilize an egg. We need it to have a tail that is normal, and we need the head of the sperm to also be a normal shape. So the shape of the sperm, how fast it moves, how much concentration of sperm we have per volume of semen is all critical to male fertility. And your doctor should, if you have a male partner, be evaluating male sperm as part of your workup, because a third of all infertility cases have to do with male infertility. So this is not just a female issue. Infertility impacts every gender, race, class, you name it. It does not discriminate. So that's why I think it's important that we touch on the male factor case here. Okay, so what is infertility? We've been talking about it quite a bit. Infertility is the inability to conceive children naturally. We recommend for couples who are under 36 years of age, the female, if you have been trying for at least 12 months unsuccessfully, it's time to seek fertility treatment. If you are over the age of 36 and you've been trying for more than 6 months, you need to go in and seek fertility treatment. And I assume all of you know this, and you're probably working with a reproductive endocrinologist at this point. But if you are not, and you're toying with the idea, I always think it's okay to go in and seek out the help of an expert. You know, in my case, I'm under the age of 36, and I was only trying for several months before I knew something was wrong. So I didn't want to wait a full year. So this is just the parameters. Do I think you need to fully listen to this? No, you need to listen to your gut and be your own advocate through this process. And we're going to talk about that a lot. Okay, so when something goes wrong, this is when we often have to turn to IVF. Okay, so before we get into IVF, I want to talk about the workup required and make sure that if all of you are working with a fertility clinic, this is going to be sort of like the general roadmap that you're going to follow for new patient workup prior to starting IVF. Most clinics have a checklist of what you're going to need because this is a surgical procedure. It's very expensive, it is time consuming, and it is mentally draining. So there's a lot that we want to prepare you for and make sure that the clinic has done before you jump in. All right, so your cycle day 3 blood work, that's that hormone panel that I talked about. Why do we get this on cycle day 3? That's because this is when your hormones are suppressed and when they're supposed to be at what we call their baseline value. So if something is off, we know, okay, is it just the cycle or is there something wrong like PCOS, endometriosis, advanced, DOR, where you're sort of perimenopausal. You also want to get a transvaginal ultrasound. So we want to get in there and evaluate your uterus. We want to look at the ovaries and get a good picture of what's going on. And on your baseline ultrasound, we can actually get a baseline follicle count. So that's where we can see how many eggs you potentially have on each ovary per cycle, which is pretty cool. We have to do Std testing because we are in IVF dealing with human gametes in a lab. It is required by the FDA and other governing bodies like the CDC and oh my gosh, anyways, there's another one for hospitals that we have to comply with, but you need to have Std testing. Every couple is going to have that done. And your partner has to have this done too if you have a partner. Genetic testing. Definitely look into this. Don't take this lightly. My husband and I was like, we don't need it. And it turned out that I had 2 clotting diseases. And we figured that out with a more intensive genetic panel workup that we had done. And so we learned that I'll have to be on Lovenox for any pregnancy. And that may be why I had miscarried after a round of IVF. So I think uncover every stone. There's nothing wrong with getting that genetic testing done. An HSG, this is a hysterosalpingogram. So we want to make sure to get a good visual of those fallopian tubes, see if there's something in there called a hydrosalpinx. So see if your fallopian tubes are open or blocked. And this will really help physicians further predict, like, can you do an IUI? Are you a candidate? Or do we really need to move you to IVF right away? And again, they're going to want to get that partner semen analysis if you are working with a male partner for IVF. Some quick stats. That should be 1 in 8, but 50% of couples conceive within the first month. Every month after that, your chances go down. And that's when we really see the 1 in 8 couples who suffer from infertility. Infertility is a medical diagnosis. I know there's not a lot of insurance coverage for it yet, but we are fighting for this every day in our country because it's just not fair. If it's a medical diagnosis, we should have coverage for this. A third of all cases are female factor, a third are male, and then a third are unexplained or involve both. Ivf success rates. This is where things get a little bit daunting. IVF is not a guarantee, and I think it's really important that you and your doctor review this intently before in your IVF workup call and your, that meeting with your doctor and that consult. you need to go over the statistics that meet you. So IVF success rates hover around 50% in general. They can be higher, closer to around 70, 76%, if you are doing genetic testing of the embryos called PGT. And that can increase with every transfer. However, IVF success rates per cycle decrease the older you get. So once you're past like that 35 mark, things tend to level off. And when you're in your 40s, you'll see sort of like a steep decline or a IVF live birth success rate hovering usually less than 10%. And that's when your doctor might bring up options of donor egg, etc. But again, it all depends on your workup. Question in here. Oh yeah. Please feel free to jump in.
Could you define
Yeah,
PGT
it's
for everyone?
pre-genetic testing. So this is when we, and I have a slide on this later, but it's when we do, we actually are able to get a little biopsy sample of cells from the embryo. It has to be it has to be a blastocyst, technically, in order for us to biopsy that embryo. We send it out to a specific lab. It's usually not done in-house. Your IVF clinic will partner with an outside lab that does this kind of testing. So your biopsies get mailed out. And then this testing can show us, it can only look at chromosomes. So we'll be able to know if an embryo is genetically viable. So does it have the correct set of chromosomes? So we can rule out like trisomies, monosomies, etc. So that it gives us further success rate with live birth because it can help decrease miscarriage rates with IVF.
I had a quick question.
Sure.
When you're talking about the genetic testing, so just to briefly summarize,
Yeah.
I got pregnant the first time I ever tried. I have a daughter. I tried, to get pregnant again. I got pregnant 6 months later. I had a miscarriage at 10 weeks, and
Okay.
I just had my first retrieval in IVF, in which I went for the genetic testing because I really wanted to decrease any chance of miscarriage. And so I had 3 eggs that were fertilized, none made it to the 5-day blastocyst.
Mm-hmm. Okay.
So as I'm going into this next cycle, the primary doctor there was really talking about, he was really strongly encouraging me specifically, based on my stats and on his experience, to do a fresh embryo transfer.
Yeah.
And I wanted to just ask your thoughts on that, because I was doing the genetic testing because, again, I wanted, as you were just pointing out, it really can decrease the chances of miscarriage. So I wanted to just get your insight on doing a fresh embryo transfer versus frozen.
That's do you mind if I ask how old you are?
No, that's okay. I basically gave birth 2 weeks before I turned 41. I got pregnant at 44 and had a miscarriage, and now I'm 46.
Yeah. Okay. So I would agree with your clinic. At that point, if you're not able to make blastocysts in the lab, your best success is actually to do a day 3 transfer. And our hope is that the eggs that mature in an IVF cycle will tend to be like the healthier ones that grow and become mature with the medication. So at that point, our goal is to transfer. And yeah, obviously there's a huge risk of miscarriage and what we call aneuploid embryos, which are genetically abnormal embryos.
Right.
But I have seen beautiful, healthy children form from day 3 transfers, fresh IVF transfers. So it, you know, it also comes down to what you feel like you can do. Do you want to risk again, because you want the genetic testing and having, ending up with no boss, or are you and your partner comfortable with going ahead and, getting to the goal of transfer?
Right. It's a really tough.
It's a really tough decision.
Yeah, it's a really tough decision, but I
know.
I really know. I appreciate, though. I thought it was very insightful for you when you were just mentioning just the fact that with the first try that they didn't make it to 5-day, and he was saying as well, like nothing really replaces the womb.
Yeah.
And if your womb is in a healthy place, then so, but again, you do take that risk. So, but it's good to hear that you would advise the same thing. So I thanks so much.
Yeah, I think a lot of fertility doctors would. So I definitely think, he wants to give you the best shot, or she. So I think it makes sense. And I really appreciate you opening up and asking that question.
Yeah, thank you so much for answering.
Of course. That's what we're here for. Okay. So, what is IVF? So it sounds like some of you have done this already, which is great to know. But I have a little image here. I don't know how well you can see it. But IVF is a surgical procedure. This is a serious process, and it should not be taken lightly because there is a lot involved. You have to take stimulating medications for a specific amount of time that come with side effects that may be uncomfortable for you. It involves the surgical removal of the egg, so that's the actual surgical procedure. It involves the joining of eggs with the sperm to make embryos. This is done in the embryology lab. And then it potentially involves the transfer of an embryo to the uterus to achieve a pregnancy. So this is like the general overview and map of IVF, and then we're going to go into each one specifically. Oh, that shouldn't be there. Okay, let's talk about medications. So IVF involves some intense medications. They, in most clinics, are still using injectable drugs to stimulate your ovaries. So these basically mimic that follicle stimulating hormone that I talked about earlier, but it overtakes your body's natural production of it. So we kind of quiet your body's endocrine system so that we can control what's going on through medications. You're typically on drugs for 7 to 10 days. However, some IVF cycles can go a little bit longer. Many clinics are now offering what we call minimal stimulation IVF. So the traditional IVF medications can leave a lot of women sick, bloated, uncomfortable. The drugs are extremely expensive. So if you don't have IVF coverage, now pharmacy is a completely different plan. I don't know how far you all have gotten with insurance, but medications are often covered under a completely different part of your insurance. Some of you might have coverage for the IVF cycle and procedure itself, but you might not have medication coverage, or vice versa. Medications can cost anywhere between $5,000 and like upwards of $10,000 per cycle. So it's no joke how expensive this stuff is. Oh. Okay. So minimal stimulation would involve taking an oral drug like Clomid or Letrozole. It grows fewer eggs, but this actually has been, research shows that it's very effective for women who are maybe more of what we would call DOR with diminished ovarian reserve, or a poor responder, they can actually do really well with minimal stimulation. And we're not pumping you with the highest dosage of these injectable medications. So we have seen much success with what we call mini stim. So that's medication. The egg retrieval, I've been through two. It's great. You go to sleep. You get a great little sleep. I went under for mine. And it involves the transvaginal ultrasound, which you're going to get quite used to in the office when you go in for your continual blood work and monitoring checkup when you're on your injectable drugs and medication. You're going to be going into the office like every day, every other day, to make sure we know the ideal time to schedule that egg retrieval. So when we get to egg retrieval, you're going to go to their surgical facility, usually in the same building, or might be in the main office if you're in a satellite office. And it involves that transvaginal ultrasound, only this time there's like a big hollow needle attached to it. And that punctures through the ovarian wall into the ovary. And they actually have this little like pedal. It's really cool. And it sucks whatever is inside each follicle. So they can see on ultrasound your ovary, and they're going to go and collect hopefully an egg out of each follicle that they see. They're suctioned into these little tubes, and the tubes go over to the embryologist, who looks through them in the microscope to find eggs. This is a quick same-day surgery. It involves, like I said, twilight sleep. So it's not general anesthesia. They're just giving you a little IV with some anesthesia to help you go to sleep. Or it involves local. A lot more clinics are doing local so that you can be awake and aware for the process. Just depends. All right. So embryology. This is kind of where things, as we heard from the question that was just asked, where things can get really emotional. During the time between retrieval and when you get your first embryology call, your eggs are going to be joined with sperm. Fertilization, we can do two different ways with IVF. We can do what we call conventional insemination, which is where the eggs are left with the sperm in like a petri dish, and the sperm will hopefully swim and fertilize the egg. They really only fertilize mature eggs. That's just the way of Mother Nature and science. So it's pretty cool. And your doctor likely won't advise conventional insemination unless your partner has great semen analysis. Otherwise, we're going to recommend the second form of fertilization, which is called ICSI, or intracytoplasmic sperm injection. Quite a mouthful, but if you want to like look it up on YouTube later, it's really cool. They're actually able to take the head of the sperm and with like the little pipette, attach it or like implant it into the egg to hopefully fertilize. So ICSI for partners with any type of like sperm or male infertility, ICSI is a great option. It doesn't necessarily guarantee fertilization, but it can help your odds. So I think first it's important to understand how fertilization works. After they fertilize, this is the time that you're going to be getting a call every day or every few days with updates as to how those embryos are progressing. There is a certain number or amount of attrition with pretty much every couple when it comes to IVF. So let's say we retrieve 20 eggs. 18 are mature, 11 fertilized, then you have 10 or 8 that are, become day 3 embryos, and then you might get less and less as time goes on. So there is a natural amount of attrition. This is normal. So you want to make sure you're talking to your doctor about where you're starting. So you want to understand your follicle count in the beginning, get a good idea of, hopefully, like when you're going into egg retrieval, how many mature eggs we're hoping to get. And then it'll give you a little bit more of an idea for how many might fertilize and how many embryos you may end up with. So our goal with this is to, we're going to end up with a day 3 fresh transfer, which is totally fine. That may be the goal for you in your case. For other people, the goal might be to get to day 5, 6, or 7 and end up with some blastocyst embryos that we can biopsy for genetic testing potentially, or do a fresh day 5 transfer of a blastocyst, or just freeze them and do a transfer later. This is the stage where embryos are graded. So they're going to be graded with a number. So 6, 5 would be sort of the day. And then they're going to get another number for how expanded that blastocyst is. And then they get letter grades for this little, I don't have good pictures of it, but you're going to see an inner cell mass and then something called a trophectoderm. I don't think I need to go into all that here, but you're going to get a mouthful when you go through this from your IVF nurse or your embryology team, who should be happy to walk you through all of this with your embryo update calls. Okay, and then the transfer process. So this is typically the goal with IVF, is to achieve a healthy pregnancy, and that involves the transfer. So this is a really quick office procedure. It's actually usually done in the surgical center as well, because that's right next to the embryology lab. And it's when the embryo is injected back into the uterus. They're usually going to ask you to come with a full bladder so that you can be guided on ultrasound and really get a great view of your uterus, so the doctor can fully see where they are going. And it's really cool. It's scary too. It's a lot of feeling, but it is painless. It takes about, some clinics will test on day 8 or 9. I think that's a little early. Other clinics will bring you in around day 12, 13, or 14 for your HCG level, which is your pregnancy test. And so this is when we find out whether or not implantation is successful for you, so resulting in a pregnancy. I did see some questions on the document that I got beforehand. I don't know if all of you are here who asked this, but about some of the new complementary tests or new innovations in IVF. And I've been there and investigated all of them personally. So some of these I've done and others I haven't, but I have talked to doctors who are doing these. So TGT, we already covered. I don't think I need to go through that again. An ERA test. An ERA test is looking for endometrial receptivity assay. So this is a biopsy of your uterus, and it helps us predict or look at your uterine receptivity to progesterone. This is critical for the embryo transfer. This hormone, it all impacts the uterine microbiome of what we're putting an embryo back into. I did this, and I found out that I am pre-receptive, so I needed a whole extra day of progesterone injections prior to an embryo transfer. And I wish I had done it before our first transfer, but it is what it is. And it gave us an incredible insight into my uterus and what we needed to do for a successful transfer. So more and more clinics are using this as sort of like a gold standard. I think we really should be using it more because it works. Another test is called the Receptiva. This one, well, it's still sort of not every clinic uses it. We need a little bit more clinical published information, but it is valuable. Mostly what it comes down to is cost. So like it's another $1,000 that you may have, that you're gonna have to shell out of pocket, which sucks. But if you think it could be helpful for you, then I recommend getting it done. We typically do this more after a couple failed implantations. And the Receptiva is another uterine biopsy, but this time it's looking for markers of endometriosis. So we know if you need suppression before we start your stimulating medications for IVF. And then the Emma, I just see something in the chat, so let me check that quickly. Oh, good question. I will definitely get to that after the slide. The Emma and Alice test. These are new, also uterine biopsies, but we are learning so much more about how the uterine microbiome is critical to live birth rates. So an embryo might implant and we may miscarry, and it could have been a genetically normal embryo. Why is that happening? Is it because of the uterine environment? So the Emma test looks for something called endometritis or chronic endometritis. That is a uterine infection. And then the Alice test looks for your uterine like bacteria, which we're all about at Binto. So I did these tests. It was really fascinating. And these are the ones I got asked about. So ozone sonotherapy and PRP. These are more treatments than tests. Ozone sonotherapy is actually using ozone air and injecting it through like a little tube into the vagina so that high quality air gets into the ovaries and helps reduce inflammation and potentially increase our egg quality. So not every clinic has this. New Hope Fertility Clinic has this in New York City, as well as Rejuvenating Fertility Center in New York City with Dr. Merhi. I was going to go to New York and do this. So I've like, if you have questions about it, please ask me. I've talked to Dr. Merhi multiple times. And then PRP, which is platelet-rich plasma. And injecting that into our ovaries to help rejuvenate them, basically, for women who are perimenopausal. And there is some good research on this. You still have a long way to go. But if you have the finances to do this, if you have the ability to get to these clinics that are offering it and you want to try it, there's no evidence that it will harm your cycle. All we have is that it could potentially work. So I just wanted to bring those up as some newer things that I have discovered through, even since working at a fertility clinic. And these are some of like the new therapies that are coming around, which is really exciting because we really need to push forward and get to better success rates with IVF. Okay, so that's it, which is great because I think we have 10 minutes left for questions. So Amy, you asked, do I have any tips for managing the roller coaster of emotions? So absolutely. Get a therapist. That's one of the best things I've done for myself, and find a mental health specialist who can really, is going to be supportive of you and be in your corner and let you grieve if you need to grieve, and just help you get through this process, because it is mentally exhausting, especially when you've gone through loss after loss, or, we're surrounded by social media, which is just like constant baby announcements, and baby photos, and it can be just devastating when it's not happening to you. So that would be one of the first things I would recommend. The other thing would be surround yourself with the support group that you need. So this includes family and friends. If you need to mute people on social media, mute them. If there's a friend in your life who just does constant obnoxious things, just don't talk to them for a little bit. That is okay. You need to do what you have to do to survive during this time, because we need your cortisol level to be lower and in a good place for you and your partner to get through this successfully. I also really recommend involving your partner. So this can really test marriages. I wish people had talked about that more. You know, one of the fertility doctors I worked with said, like, if your marriage can survive IVF, like it can survive anything. And I really believe that it tests you like nothing else. You know, it's just so critical to remember that you are a team during this process, and constantly like come back to each other and figure out what support each of you need. Because like the intimacy is hard, it's all hard. Financially, it's hard, and mentally, it's hard. So make sure, you know, if it's not just the therapist for you, maybe you find a couple of counselors if you've gotten to that point. And I think that's totally normal to do that.
Thank you. That was a really informative presentation, and we got a bunch of questions early on, but I'd love to open the floor to anyone here that would like to ask questions. So I'll leave it to you guys.
Yeah, feel free to jump in on the chat or just pop in and say I have a question. And I forgot a slide I have to go. I wanted to go over, but while you're thinking of your questions, I can talk about it. You know, to optimize IVF success, I do think there are little things that you can do. I want you to remember it's quality over quantity. So we kind of talked about this already with one of you who jumped in and asked your question. It's about quality. So like for day 3 transfer, the womb is best. So it's getting in that, like the embryos in that quality incubator, right? Or it's getting that quality embryo over like having 36 eggs that may not be the best quality. I want you to advocate for yourself. If something doesn't feel right to you, or you need to push back on your doctor for more answers, do it. You need to lean in. This is an expensive process, and you deserve the best care, and you deserve to win in this process, and you really need to fight for yourself. We make supplements at Binto, so obviously I believe in supplements. I do think they make a huge difference. I think it made a huge difference for our second cycle. Diet is critical. Cutting out inflammatory foods can really make a big difference in quality of eggs and sperm. And then obviously lifestyle and environmental changes. So get plenty of sleep. Try to cut down on stress, which I hate saying because it's a stressful process, but invest in the self-care that feels good for you. And that was it.
We got a question about just clarifying the form of sperm injection you were speaking of.
The what injection?
Sperm injection.
Yeah, it's called intracytoplasmic sperm injection, ICSI. It's a type of fertilization.
And one general question I think that's really important to ask is, how soon should couples begin planning for IVF before they start?
It takes, well, there are a couple things. Your clinic, Your clinic may have a wait list, to be honest with you, or they may only allow certain stim starts per week, so they can control how many surgical procedures they're doing so they don't become overwhelmed, so they're not going over capacity. So you may be mapped out for like 3 months from when you have your follow-up visit, or you may be able to get started right away, but it definitely takes at least a month, sometimes more, to prep. Some of you might have to go on birth control pills to suppress you before you're even able to start any of the injectable medications and go from there. So it's not a short process. This isn't like a quick in and out, okay, I'm ready to do IVF next week. That's definitely not how IVF works or clinics work. That's a good question.
Suzie,
I think a lot of people don't realize that. Oh, go ahead, Olivia.
Hi, my name's Olivia. I'm on day 6 of the stims, and I have a question about avoiding, or anything that you can do to avoid some of the more serious complications of taking the medications, like a twisted ovary, or I've forgotten what it's called when the fluid,
ovarian torsion and OHSS.
And when the fluid like enters all those things, if there's anything that you can do to avoid that or to have less risk.
Yeah, so if you are at high risk for that, Olivia, your doctor probably would have put you on a medication protocol for what we call a hyper responder. So someone who's going to be at much higher risk for what we call ovarian hyperstimulation syndrome, which is exactly what you were talking about, having that fluid retention. They're going to put you on that specific protocol so that way you can take a certain trigger shot before your IVF retrieval to limit the risk of you getting OHSS. I got OHSS. It sucks. You can also take another medication called cabergoline, which is going to help with those symptoms. So it'll be a lot less severe. And make sure you're drinking plenty of, sorry, my husband's using the ice maker. They're going to be, you want to make sure you're drinking plenty of electrolytes post-retrieval. It usually happens a couple days after retrieval is when you're going to feel like the most bloated. So you want to be taking electrolytes and eating protein, and you want sodium. So salt actually helps draw fluid out. So we think don't eat salty foods. You actually want to eat salty foods, and just take it easy. You don't don't exercise. I mean, I could barely walk and I was so full and bloated. But that's exciting. You're on day 6, and I hope you don't get OHSS. I'm sure your doctors are going to be monitoring you closely and talking to you about that.
Thank you. That's super helpful.
Everything goes well. Yeah, of course. And then we got something else. Would I recommend a saline sonohystogram? It's not required. I had a terrible, I think it was incredibly painful. What you could ask about is getting a hysteroscopy instead in the office if they allow that. But I do think prior to IVF, they are going to want some type of cavity evaluation. So that means a saline ultrasound, so the sonohyst, or they are going to want to do an HSC. Take Advil ahead of time, please. It feels like a big cramp. It's not comfortable, and I feel like they don't always warn you about that. So take Advil, and they're going to give you a pad after because you're going to be leaking the fluid.
Well, Suzie, thank you so much for your time and for answering everyone's questions so patiently. This was so informative, and I hope everyone else found this to be as
thank you for your questions. I hope this was helpful. If you need me, you can find me over at Binto. We're at mybinto.com and at mybinto on Instagram, and I'm there a lot. And I love to chat. So please feel free to connect at any time. I'm cheering for you.
Thank you so much, Suzie. This is great. And everyone, we've got a recording available. We'll have this recording available for everybody to look at. We'll send an email out probably later tonight or tomorrow. But thank you so much for your time. And we'll be having another event next month, so stay tuned for that. Have a good evening, everyone.
Thanks,
Thank
Amy.
you.